While everyone is getting seated, it gives me the opportunity to thank all of you for being here, and particularly to acknowledge the extraordinary 39 years of the Srinivasan Endowment Oration. And it is humbling beyond belief to actually be part of this. It's been particularly wonderful to be here with my colleagues and to be inspired by their work. And if any of you were in the audience with the talks over the course of the afternoon, I think we can all appreciate how this field has evolved, and I hope I can really give an adequate representation of where the field has gone, but I'm inspired by my colleagues. The hospitality has been extraordinary. It's my first time to India, and seeing what goes on at NIMHAS, seeing the interest in the synthesis of brain and behavior, bringing together psychiatry, neurology, neurosurgery in a humanistic goal. I hope this talk will help you to appreciate that this is on many of our minds, and I'll try to take you through the journey that I've been on as a neurologist that became interested in depression through the lens of the brain and brain imaging. I'm going to talk about grant-supported research that really goes back 30 years. I actually trained, Bud Rowland was my chairman of neurology, and Professor Pedley was also one of my teachers. Professor McCann's father was also one of my teachers and one of my jobs. So it's really extra special to be here and celebrate the legacy of many important people in my training. My disclosures are just to point out that I'm going to talk about the evolution of actually an invention to treat depression, and I consult to Abbott Labs that is making some attempts to commercialize it. I also want to point out up front that, that this is a journey that involves many, many people, and that again, even as the leader of a team, one is really lifted up by the work and the focus and the criticism and the drive of people that come from many, many perspectives. And so my work has always reflected an integration of neurologists, psychiatrists, and neurosurgeons, but physiologists, computational modelers, engineers, statisticians, psychotherapists, and I hope you'll get a flavor that everyone's input is important to the mission. Now, with that aside, I actually want everyone to just think for a second really about what we're treating. Because we can use the word depression, we all think we know what it means. And if you actually have never been depressed, we can't know what it's like. But I want you to think about what it must be like if you were in a state, as William Styron described his own depression, as a state of active anguish in which one is nearly immobilized in a trance of supreme discomfort. What does that even mean? And if you're a neurologist, you're asking yourself, immobilization I get, trance I don't get, discomfort we all know. And how can we be stuck in that state, and why is that called depression? And if you talk to a depressed person, and this is one of the brain stimulation patients that I will tell you about, this is how she described the state that she was in, this agonizing state that, as she said, when I'm depressed, everything, standing, stepping, speaking, moving, pursuing a train of thought, gets hung up on that loop of hesitation that ends up feeling like paralysis. If I finally do break free, my sense of self gets left behind. It is as if my momentum comes at the cost of identity. That is one twisted, awful sounding state. And if you combine this active state with an inability to move away from it, we're talking about the extreme of depression. And this is where I want you to think about, what would that be like if every treatment that we have for it didn't work for you? So before we get into the nuts and bolts of how does a neurologist study depression and why is a neurosurgeon involved at all, let's think about the problem. And here's a map of the world. The estimates are 5% of the population is affected with depression. It amounts to more than 300 million people worldwide, and I think for the audience here, that's 56 million people in India. And you're served by 4,000 psychiatrists. That's painful. It's women more than men. It affects all cultures, all socioeconomic groups. It's now seen as the #1 cause of disability worldwide, and the estimates that 28% of years lost to disability, including death, is due to depression, which leads the mental illnesses. India is up there. United States has more, North America, but India and China are highly represented. Now, the good news, as I start out with such a negative set of facts, is the fact that depression, most of the time, is eminently treatable. The problem is, despite the treatments, and there are many, medications, different kinds of psychotherapy, different kinds of electrical and brain stimulation, non-invasively, aren't always effective. And importantly, about 40% of people, when they present with the first episode of depression, actually don't get well. Also, though, the good news is that every person who's depressed, if you stick with it, trial and error generally helps you to recover. The problem is we don't have ways, we don't have biomarkers, we don't have tests that'll help us to match a patient to the treatment that's best for them. The bigger problem is that despite being treated, depression is an episodic disorder. It means you have episodes, it's treated, and it can recur. That about 10% of people with depression become resistant to the treatments that they previously responded to over time. And that's both a very interesting negative plasticity question. How does a brain that's repaired actually then go wrong? But the problem becomes we have few options once you actually fail electroconvulsive therapy, one of the best treatments that we have. And that really puts people in a fairly agonizing state. If you have no options, many people take their own lives. So as we think about how might we leverage, or even think about any novel therapeutic, it's something that's been a recurrent theme over and over again in the conclave, in the talks this afternoon, that the cutting edge of science, we delude ourselves. Actually, important things are missed all the time, and we revisit them. And so anything we do that is perceived to be novel is generally rarely about something you discover that's completely unknown. And it's really found when you actually know enough to ask the right question or build the right tool. And I think that is really the mindset I want you to be in, is where I was in 2001 in Toronto, studying depression with imaging. What were the set of facts that were in play at that time? We'd been using for 20 years structural and functional neuroimaging. We could see a brain in action, and I'm going to show you. We weren't just stuck with waiting till someone dies, trying to look at a dead brain and actually seeing nothing to explain the great suffering that people had. And that goes back to Freud. They looked at brains. They were neurologists. They wanted to see what could be wrong with people who were mentally ill, and they couldn't see anything. They didn't have the tools. The second thing that became possible as we started to think about DBS for depression was the advances in stereotactic neurosurgery. And at that point, they were amazing. The dark ages even of them, but they'd already been using DBS successfully in the clinic for other neurological disorders. It was those combination of factors that allowed us to journey into this new potential approach. Just briefly, deep brain stimulation involves neurosurgically implanting a small electrode in the brain, hooking it up to a pacemaker, as you would do in the heart, under image guidance and specialized tools that the surgeons have to guide this wire precisely to a spot in the brain of their choosing. One can then deliver small amounts of current and essentially provide a pacemaker to the brain. This notion of how would you do that? Well, we have surgeons here, and I won't pretend to explain the magic that they do. But what was important is, how do you map the brain to actually know where to put the wire? And as in many fields, the where is absolutely essential. And like I said, off the backs of all of the work that had gone on in movement disorder, we think now so nonchalantly about all of these brain disorders, obsessive-compulsive disorder, depression, addiction, memory problems, as being circuit disorders. This wasn't the logic before, except in movement disorder. And so the idea that there are an organization, a wiring diagram, a orchestra of different regions that actually communicate with each other in rhythms, that communicate different kinds of information, that we might leverage that to figure out where in the brain is wrong so that we might tune it explicitly and return the rhythm of the brain to normal. So what we need to do, which is what the Parkinson's specialists needed to do, what we all need to do is, first of all, why might we want to do that? We might want to affect certain symptoms. We might want to deal with side effects. We might want to prevent prevention or progression of a disease. But in the case of depression is, we don't have other options. We're dealing with resistance. We might like to know what we expect to have happen. Do we want to block activity in the brain? Do we want to enhance activity in the brain? Do we need it all the time? How long should it take? But most importantly, we need to know where to stimulate. Can we stimulate anywhere? I've got this circuit. Maybe you can stimulate anywhere that's connected to anything else. But as you might imagine, the brain is complicated. All regions don't behave alike. Many regions are connected to many other regions, so precision may be important or may not be important at all. And we need to figure out who would be appropriate. So how do we go about even thinking about that problem? Again, we look to our neurological colleagues who already kind of cut down the trees to help us to kind of guide the path. But there was something even more interesting about looking at depression relative to Parkinson's, and you can see it by just looking at the pictures. There's something wildly similar between patients who have Parkinson's and patients who have depression. And at first you might say, how can that be? Because in Parkinson's, the primary symptoms are motor, tremor, rigidness, slowness. But in most Parkinson's patients, they have problems with their thinking, problems with their behavior, including depression, problems with their drive states, their autonomic nervous system. And you flip that around and you think about major depression. The prime symptoms are mood, negative mood, but also lack of interest, anhedonia, apathy, as well as disorders of drive, eating, sleeping, appetite. Very similar, not exactly the same in terms of how they present, but the same genre of symptoms. But in depression, you also have this distorted way of thinking. you feel guilty, you want to hurt yourself. You know, what a cruel illness that not only are you suffering and you can't function, but you actually somehow think it's your fault. And that's where things start to deviate. But we start to have some clues that we might really use what's done in Parkinson's to help guide our thinking for depression. And the way we do that is to actually not get so into the details, lower the resolution, not, you know, make the details more refined. Because for all behavior, emotion drives our motivation and drives our intention to move our actions. And our actions then feed back and tell us if that was good or bad. And it's a constant cycle that we interact with the world. It gives us reinforcement or not. And these kinds of basic actions, where action or motor was very well defined in the basal ganglia and the focus of attention that led to really the targeting for movement disorder. There are parallel systems that actually accommodate motivation, intention, as well as movement, that we can examine and see how which dominant circle actually is the driver of the others. And part of doing that was to say, let's use neurological tools. And we were drawn to the fact that it was well described that people can have lesions of their brains, a stroke, an accident, that actually damages the frontal lobe. And that was found to be the area of the brain that was most associated with depression that occurred after a stroke. And that the observation that it wasn't just you would be depressed too if you suddenly couldn't move your arm. No, that there was a relationship between an area in the brain and the presence of an emergent new depression. And when we had access to look at the functioning of the brain, and on the right side, those are PET scans giving an image of brain glucose metabolism, comparing a healthy person to a person who's depressed. You're looking at the side view, the nose is to the left. You don't need to be a radiologist, a neurologist, or any kind of expert to see that those two brains are not the same. And the whole front side of the brain, the frontal lobe, is underactive. And so intent, motivation, apathy, those negative symptoms, the kind of absence of movement is so prominent. It's the best replicated finding in all studies of depression. And it's a different part of these circuits than you see in Parkinson's. But we still have the issue of, we've got part of the brain that consumes your energy and your attention. Where's the part of the brain that's going with the active anguish? So far, I've just shown you areas of the brain that seem underactive. Well, we did an experiment back in Texas because we were studying depression and focused on the low frontal activity. And with Mario Liotti, we actually did an experiment where we provoked the experience, the feeling of transient negative mood. Now, this is very different from being depressed, because when you're depressed, you're stuck sad. But we thought in a very simple-minded way. Let's just look at how the brain changes over minutes as anyone rethinks of an event in their life, generally a loss, and use it to remember how you feel, how you felt at the time of that loss. And quietly in a scanner, you can actually evoke intense negative emotion in most people over minutes. And at that point of when that tearful feeling overcomes people, we took the picture. And the picture we saw is on the right. And what that is showing, and really the most kind of, there were two parts of this experiment. Part of it was what we wanted of it, and part of it was a total shock to us, that we had this area, this deep in the brain, this little red dot, seen on the side, not the frontal lobe, here's the frontal lobe, and here from the front view, right in the middle, we saw this area of overactivation. As you went from neutral mood to negative mood, this area was the most active in the brain. And this is the subcallosal cingulate, area 25. It was named after an anatomist. It's just a kind of bookkeeping, but area 25 we'll use for short. And this experiment seemed like a failure because we were looking for the sad part. We wanted to get rid of the frontal part. We just figured we just needed to provoke someone. And what we got was the most important finding, which was that not only did these limbic, these emotional areas light up, but we turned the frontal lobe off. And the more intense your negative mood was, the more it was yoked to the decrease in the frontal cortex. These regions are tied together: emotion and thinking, emotion and attention, emotion and movement. When we all get sad, you actually turn inward. We all do. You get introspective. You think about where you are. You actually don't move as much. And then when the environment provokes you, you move, the emotion goes down. It works in harmony. Negative emotion is useful. It helps guide us, but it should never be stuck. And what we also learned was that this pattern that you could evoke in just minutes was mirrored exactly by the pattern that you could see in depressed people who were successfully treated. A successful treatment had normalization of the frontal abnormalities and turned down the activity in area 25. So you can start to see that we were really wondering. We saw this with different medications. We saw this with various kinds of treatment, that this kind of yin-yang, this push-me-pull-you, this yoking of the limbic and the cognitive was present if you could get better. And our logic was, if you can't talk it, drug it, shock it into balance, maybe you just should go in directly and actually block it and kick it. And that was really the total logic of what we wanted to do with brain stimulation. So back in 2003, Andres Lozano, a neurosurgeon in Toronto, and Sid Kennedy, a psychiatrist in Toronto, we joined forces to ask this question. Could we implant someone with this well-established deep brain stimulation for Parkinson's by going at area 25, with the idea that in Parkinson's disease, if they applied small amounts of high-frequency stimulation, they blocked activity, they could stop a tremor, they could make Parkinson's patients move. What we thought is we wanted to block the activity in area 25. We'll put it next to area 25, and we'll put the high-frequency stim. We'll block the negative mood. We'll release the frontal cortex, and it can go about its business. And it was a very naive idea, because it turns out that brain stimulation at high frequency doesn't just work by blocking activity. It's wildly complicated. It activates areas of the brain, decreases areas of the brain. And it turns out that it wasn't just area 25 we were hitting, but that was our logic. And so we took an MRI. We estimated where area 25 was. We put in one electrode on each side, and we turned it on. And we followed patients for 6 months. And we had 6 patients that were, extremely ill and refractory to all treatment. And we found that over time, this is the severity of the depression, with high number being the starting place. And even early in the hospital, they had actually dropped their scores and were profoundly better. This little bump here is when we actually put the battery in and turned it off and gave their brain a rest for recovery for a week, and then turned it on, and after 2 months or so, all the patients are doing reasonably well. And then 2 of them lost the effect, and the other 4 did much better. And we were really encouraged because these people were unresponsive to any treatment. And when we looked at how our PET scan signal had changed, The overactive area 25 had decreased after 3 and 6 months of the stimulation. So our hypothesis had been not proven, but supported, and that encouraged us to move forward. But I want to draw your attention to something that happened in the operating room. And you know, everyone who works in this field, and you know, you have someone awake in the operating room, and it's extremely stressful. It's stressful for the doctors, stressful for the patient, as you can well imagine, to be kind of bolted into a head holder, to have your brain open with someone working behind you, and to have people in front of you asking you questions about what are you experiencing. And we were actually not expecting anything to happen in the operating room. And in the very first patient, not in the first place we tested, not in the second place we tested, because on that electrode, you have 4 places to test on each side, and you can make adjustments. But we got to the third contact, and the woman suddenly felt very different. And she started describing that a void had just lifted. And I didn't know what a void was. Everyone that you treat with depression, if you get ECT, you generally aren't better right away. Most medications take weeks. Psychotherapy takes many weeks. And so it wasn't in every contact, it was subtle. But the next day in the hospital, we tested it again. So I'm going to show you, this is the only video, but I think it's worthwhile because we missed the significance of it, even though it was incredibly profound, because it really didn't happen over and over. But it did happen again in this first patient the day after surgery. And I'll show it to you. This woman has had the electrodes implanted. These things hanging the battery has not been attached yet. We're going to now take the wire, we're going to give the stimulation, and she's going to describe first what she feels like. And then in the second panel, we're going to turn it on, and you'll see what happens, hear what happens. What I want you to do, though, is also just look at her face. Don't worry if you can't hear it real well, but just look at her face.
And that sensational void, what would you rate that as right now, from 0 to 10, from being the most severe void you can imagine?
I'd say 5, because in many ways it's, I don't know how to describe it, it's like a nothingness. You know, people talk about the black hole, the black depths of depression, the black hole.
You're still in that hole, do you think?
I feel that way. Like I don't feel. You know, I don't. Yeah.
You hear the paucity of words. You look at that discomfort on her face. She can't even get the words out to kind of describe what she's experiencing, but it's there. And here's what happens when we turn the stimulation on.
Well, I feel calm and harmony. You know, I'm feeling like I want to smile or laugh or joke around. I'm looking at everybody's expressions on their faces. And,
you feel more in tune with the group?
Yeah, more in tune with the group, looking at everybody's expressions and...
So the funniest thing is we're sitting in a room with 4 exhausted neurosurgery fellows who didn't really know what they were doing there. She was responding to the open mouths of these surgeons who watched this happen in real time. So I always am amused to, it was profound because no one was expecting it, and we all sat there and experienced together. The other thing that I think in retrospect was so profound about that first experience was the fact that she was connected to them. And she went from inside herself to outside herself, which is one of the most painful things about being depressed. So we did more. So with Dr. Lozano and Dr. Kennedy, we added another 14 patients for a total of 20. And we saw this same kind of pattern. About 60% of them had this response that even some had that rapid effect, some didn't, but the group that got well and stayed well. And this was a study published out to a year. Dr. Kennedy went on to follow the patients and at 42 months, maintained that kind of effect with ongoing stimulation. When I moved to Atlanta, new team, new surgeon, new psychiatrist, we did the study again, and we got a similar effect, but not quite as good. And everyone was lamenting, was it difference in patients? Was it different? We had done a 1-month blinded period. But that, by the time we got to 2 years, we actually had an 80% response rate. These were people that had been in episode 4 to 5 years. They had tried, 15, 16 medications, multiple trials of ECT. The best ones were actually patients who had previously responded to ECT and then had another episode, relapsed, and then couldn't respond. So we thought we were onto something. Enough so that St. Jude Medical, the device company, instituted a multi-center randomized clinical trial to make this commercial. And 15 centers, very ill patients, what we thought were quite comparable. 6-month study, everyone implanted active stimulation versus no stimulation. And actually they stopped the study at the halfway mark after 90 subjects because in fact, active did not beat sham. They were equivalent. And it wasn't that there was that same 60% response rate in everybody. It was only a 20% response rate. Very few people got well. But because you have people implanted, you have a rolling enrollment, you continue to give people stimulation, you start to give other supportive psychotherapy because no one is any longer blinded. As you followed all of these subjects over months, they were coming in every 3 months, you started to see an accumulation of response. At 18 months, half of them were better, and that was sustained. We have a contradiction. Other centers started looking at other places in the brain. Everyone that looked at it in an open way, meaning the doctors knew it was on, the patient knew it was on, had these 50% response rates, but when companies went to try to do it in a blinded way, it again didn't go well. So many, it's not a huge number of people that have been implanted, but that there's enough patients implanted that continue to do well that we need to understand what are we actually missing here. And this is where actually the story, I think, becomes extremely interesting. I'm having trouble with because the enthusiasm that there was when we reported the first cases, everyone went wild. And then when it goes a little wrong, you go 3 steps forward, 2 steps back, or even 1 step back, everybody moves on. But we still have to deal with what did we see to begin? What are we missing? Is it us? Is it them? Did the surgeons does it need to be so precise that the surgeons missed something? Did we pick bad patients? Should we have measured something else? We needed to understand what we did. And we went back to what we did always, is try to understand what's different between the people who do well and the people who don't. No one gets 100% market share in anything. We're trying to figure out how to match people for the treatment that's best for them. And we have people in which this may be a treatment that is at least working for them. And it's really important to ferret this out because the durability of this effect is unlike anything that's reported in people this ill. On the left, the data on the more episodes you have, with successive episodes, the likelihood of remaining well a year drops considerably. So to have a group of patients that get well and stay well, not 3 months, 6 months, a year, but extended now over 10 years in subsets of patients, it looks as though 50% of patients will actually be well 50% of the time, and these are people who couldn't respond to anything. And if the battery dies, they lose the effect slowly and it can be recaptured. So there's something about it that's behaving differently that we should understand. And to us, the most important thing as neurologists and as imagers was to understand the where. Because the where is something that we can address. I don't know who the right patients are, but I do know that with the tools we have, we can figure out, is there a variance of where we placed it? In the first pass, it really looked on the MRI that the place we were stimulating, the active contact, was identical between the responders and non-responders. So you'd say, surgeon did their job, put it exactly in the right place. But by using the other kinds of imaging in the second panel on the left, we saw that it wasn't about just turning down the activity in area 25. It was about connecting and ensuring that regions connected to area 25 also changed their activity. And that was the difference. And because we also knew how area 25 was wired, what the white matter connections, the cables, the way in which communication occurred, we now had ways in which we could make those pictures. It's called tractography. And you can see on the right panel, who would have thought that stimulating in one contact separated by 1.5 millimeters away could make a difference? Surgeon didn't, none of us did. But when we actually analyzed the data, you can see in the middle panel on the right and the lower panel, one contact, those are the connections that are hit by making a small difference. A lot in common, but the difference must be meaningful. So we started to ask a question, and again, an imaging scientist, a psychiatrist, and an engineer. Can we model what are we hitting in common with everyone that gets well? Let's not deal with people who don't get well. People can be non-responders for all kinds of reasons. Let's focus on what we did correctly in the people that have recovered. And it turned out that there was a common pattern in everyone who got well, identically, that we could then use and even see that the patients that got better over the year, that they had missed the full combination of these connections and then had, by trial and error, gotten into those connections. And we now don't have a point to stimulate. We have a whole network to stimulate. And so we have 4 different roadways in the brain to stimulate. And so then the next question becomes, let's put it to the test. Let's take our blueprint. Let's drive around on one of these tractography maps in that person. Let's find the place in that person's brain that can hit all of these connections all at the same time, and have Dr. Gross, our surgeon, put one of the contacts of our choosing there. And now let's just stimulate their same parameters and see what happens and not make changes. And what we found was that instead of 40% getting better, it was nearly 75% getting better without making any other adjustment to anything else we did. So we're encouraged. But we also saw something else that brought it back to that patient I showed you. The better we got at actually doing the implant, the way in which people got better, the trajectory of the response changed. So the red line almost looks like just a line, a linear change over time. But the green line is where actually we did the tractography guidance. And if you'll notice, everyone starts the same, but here's this big drop that actually stays stable. That is actually after a small amount of exposure to the stimulation in the operating room in the right place. A rest for a month doesn't actually go back to where it started. And when you turn it on again, it goes down again. And this blue line is our latest group. And the only difference about that latest group, we're using a different device, but really stimulating the same way, is we now give repeated stimulation in the operating room, not just on one side, not just short amounts, but about 15 minutes of bilateral stimulation in the correct place. And as you can see, there's a much more dramatic drop. And if the cardiologist that was in the meeting earlier is here, this is cardioversion. I like to see this, that we reset them in the operating room. And then there's a carryover when it's off. And then we stimulate and actually have got something different. But there's 2 phases now to this recovery. So we now need to be thinking out of the box. How do we go from a patient saying, whatever you did, I just shifted? This is really, for the physicists, this is a nonlinear state. This is a bistable state. People are in a local minimum. They can't move. Stimulation is applied, they're popped out. But that second state isn't so stable either. But with continued stimulation, the patients describe that with their own work, which they'd never imagined they had to do, there's the evolution of the recovery. So this is where, using all of our tools, we can start to say, how is the brain changing? What's changing first? What's changing second? We start to see that area 25 changes in the period from the operating room. Once that's affected, it's done. But remodeling the cortex, the thinking brain, the frontal cortex, takes time. And you don't see the effect until you get ongoing stimulation. And this is this bar here. The important thing is the people who didn't get better kind of stopped having changes in their frontal lobe. So we start to have a way to think about, we need ways to track what happens in the brain faster. And this is where the technology is really helping us, because now we have technologies where we can measure the brain signals all the time off the battery because there's a chip and a recorder. And we can start to look at the brain wave activity and see if it can give us a clue to this transition. Or we can bring them to the lab, or maybe we should have them just tell us how they're feeling, or maybe we should monitor how they move. We've suddenly got all kinds of ways that we might think about it. But again, observation, listening to the patients. We've gotten now, how do you rate void? I have no idea. You know, you use every rating scale and realize your rating scales are inadequate. So what we started to do is just let the patient tell us what it feels like. And here are the kind of things people say: gnawing, sticky, quicksand, or paralyzed or disconnected. And what we want to know is which of those things change, and when they're in the operating room, those are the things that they monitor. And what you see, where we thought that to call it a depression switch was wrong, it turns out that depression switch is part of it. And that one patient brought this picture to the operating room. I had no idea what the point of this picture was. To her, she couldn't even put into words what it was to be drowning in that sea. And when we were in the right place, all she said was, "I'm on the rock." And it took some questioning to wonder what rock she was talking about. And she said, "Look at the picture." I don't know what that is. I don't know the computation that explains that, but that is something that happened in real time. And you can see the kinds of things that patients described. They feel lighter, they feel less heavy, they can breathe, the tension is gone, the pain is gone. And when the pain lifts, they feel connected, optimistic, and they want to do regular things. Walk my dog, make some tea, clean up the house, see my friends. And we can start to parse in the most basic neurological ways, what connection were we in that went with these different changes? and we could start to see which part of our blueprint is driving what symptoms. So, sorry. If that helps us to know what to do in the OR, now we need to actually look at what is the hard part of recovery. What's the slow part? Because everyone who's ever taken care of any person with chronic illness knows. You start to get better, and then do you trust it? If you've always relapsed, when is it going to come back? How do you hold back? How do you help someone to actually lean in and use being well? And what we saw in our numbers was that you started to get instability, not early, but after 2-3 months, when your family expects you to start doing something. When you start to realize you've been ill, out of touch, what are you going to do? How do I get a job? Where are my friends? And that different patients have these instabilities in different ways. And the psychiatrists have to determine and start to learn, no, you're just having a bad day, hang in there. We need to get you into therapy, versus, no, I think you are needing an increase in dose. And this is where machine learning, what signal do we use to know? And this is where we are now, and that the new technologies really need to help us. And what we're doing is, with the brain signal, with machine learning, and accepting that we have imperfect readouts, but can we see if our clinical severity readout has got a brain correlate that we can track off the device? And it turns out we can. But we start to see that where it looks as though the machine doesn't match the rating scale is where the machine, the brain, says you're fine, and the rating scale says you're sick. And so we're really starting to reverse what is well and how should we measure it, and how can we start to distinguish what is the illness signal from just the ups and downs of everyday life. I think the future is also not about not talking to patients, but actually using the information that we have that really helps us, and the obvious things. We know all about how muscles of facial expression move. Anybody that sees anybody that is negative, you can tell when someone you care about is in a low mood. But when you're depressed, your face is wrong. You know it's wrong. You don't think your own face reflects how you feel. You don't know what other people are getting from you. And you can see that patient. You don't need a word. You don't need a rating scale to see that that person is different. And what we've started as a shorthand in the lab, we have a joke. They look different. They look different on that operating room, and you can see it in real time. Then the next thing that happens is they do more, even though they're not really aware of it. And then they just do stuff. And it's not till later that they put together their body moving, their intent to do something, that the natural habit of life is just kind of back in gear. So we're trying to figure out with new technologies how to get better pictures, how to steer the current to different parts of our network, how to get different readouts in the brain. Maybe we can analyze the voice, maybe we can analyze the face, maybe we can just watch them move. And that's part of the intent of my new colleagues and my new surgeon, Brian Capel, and new psychiatrist, Martin Fagui. But we're also partnering with our movement disorder colleagues. And we're looking at, again, the imaging, the electrophysiology, the computation, because all of this together is how we'll move the window forward. Now I'm just going to end, because I started with the patients, and I want to end with the patients. You know, what must it be like, you know, to imagine and live with a machine, and also to have the expectations of what is going to happen when you enter into an operating room. You're entering into an experiment. And as you come out the other side, what patients become very aware as they look back is articulated here. this patient, brought this little painting. And I think this is where we all are. Life is hard. But that it's worth the struggle. That when we work on these kinds of things, we need meaningful relief for patients. We can't delude ourselves that we're doing something and we have a picture of it. It has to be meaningful. But we actually now need to develop the rehabilitation strategies that maximize what the machine is doing. And patients need to be taught new habits. Feeling negative is not necessarily being depressed. And again, this patient recognized how much she had to learn and that she was very lost as she was recovering. And as she was figuring out, the one thing she was very sure of is that life was hard and she was overwhelmed by what she was going to do, but she was definitely no longer sick. I'm going to leave with this other metaphor. I think, the cardiology metaphor, if you can have chronic heart disease, get a arrhythmia, and maybe all the operating room is at cardioversion and you put in a pacemaker, and then you go back to how you're going to exercise and kind of maximize your chronic heart disease. Or maybe it's actually like a broken bone. And I think in a very concrete way, it's more like a broken bone. You don't try to run on a broken bone, and you actually don't try to use yoga or physical therapy on a broken bone. Fix a broken bone. And when you fix a broken bone needs some time to rest, remodel, till you're sure it's solid. And if you start doing something on something that's not quite healed, it hurts and it's a useful sign. But once the bone is healed, you have to rehab, and it doesn't feel so good. You have a trainer, you have a guide. Passively, someone moves your leg until you trust it, but then it's about you. You have to relearn, you have to exercise. It's hard. And then eventually, it's a plastic change. You may be better than you were previously. The last thing is I want you to listen to an interview of one of our patients in Atlanta who was interviewed for a program on BBC called Digital Human. And it was actually a provocative interview about patients as cyborgs. And there are people who like putting chips in themselves to monitor themselves. And I asked this patient who owns and talks about the device to actually go on the show. And I want you to hear it because this is the ethics of this. When people talk about you change people's personality, you make them somebody else, what are you doing? You listen to what Brandy has to say, and then we can discuss it.
When you forget the technology is even there, once that transformation is complete, are you more or are you less human? For Brandy, the answer is clear.
Being a cyborg absolutely restored my humanity. Depression had wiped out my personality, my ability to cope or function, my ability to interact with people. And becoming a cyborg has restored my ability to be a member of society and to have compassion and empathy and to interact with people. So I am now part of the people around me because I have this implant.
And
I am a cyborg for the rest of my life. And I'm okay with that because it gave me a life. But it is something that is part of my identity now.
Thank you.